All right. Tak pasti. Saya pun tak tahu. Okay. Okay. Macam mana dah tahu berapa orang dalam? Tak boleh tengok lagi. Oh, dalam YouTube. I see. Ada orang forward ni. MC ya, MC yang kata tinggal situ. Iya.
So usually we finish with one liner. Dr. Benny. Benny. Oh, H-Star. I'm guessing. So, di end tadi kali kau tak sih, sisi nama sisi. Itu kan senang. Saya ikut ilmu.
All this water.
Tak ada hari sekian. Ini kan. Dengar ke?
It's on. Itu mana? Ya, itu tak boleh tak boleh. Ada speaker.
Okay. Alright. Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh and very good morning to our honorable guest, Dr. Abdul Haris bin Muhammad, NNP Executive Director, Dr. Faizal bin Zainab, Deputy Director, Hospital Director 1, Dr. Tengku Anas Fatih bin Tengku Ahmad, Deputy Director Hospital 2, Dr. Nozilawati Muhammad Ghazali, Deputy Director Hospital 3, and Head of Department, Specialists, and the rest of HRPZ staff. First and foremost, I would like to thank you for everyone for allocating time to listen to our CME today. I am Dr. Amalina Jamil from the ONG department, will be your MC for the CME session today. Before we start our CME today, I would like to give a few announcements. Number one, to sign in for attendance, kindly scan the QR code on the screen that will be displayed before and after the CME session. Or you can use attendance link at a live chat in YouTube channel. Second announcement, for those who join the CME via online, any questions can ask at the chat box in the YouTube link. We are very fortunate today to have Mr. Pranjit Singh with the topic of colorectal cancer, how young is young. Without further delay, I would like to invite the speaker of the day to present this ME. Thank you.
Hello and good morning. Everybody can hear me? They can Okay, hello and very good morning to all the hospital directors, deputy directors, head of departments, head of units, all doctors, paramedics, and healthcare workers joining the CME today from across the state of Kelantan via the YouTube link. So my topic for continuous medical education this morning is colorectal cancer, how young is young? So the outline of my presentation, first I will present or rather discuss two case presentations of young colorectal cancers, which we have seen in our department. And then I will share a little bit on our HRPZ experience on dealing with young colorectal cancer patients. And then some risk factors on who develops colorectal cancers. And then the most important part of my presentation will be the screening for colorectal malignancies, which is very relevant for all of us today. A little bit on the staging, and then some principles on how we manage these cases. So I'll straight dive into it. So the first case presentation is a 13-year-old boy. I repeat that, a 13-year-old boy. So let that sink in. So presents with no medical illness prior to this, coming in with lower abdominal pain. Examination findings were general examination unremarkable, no cachexia, presenting with peritonitis. So usually in a young patient like this coming in with peritonitis, we think of common things: appendicitis, perforated appendix, Meckel's diverticulitis, perforated Meckel's diverticulum. So it's a straightforward thing. We proceeded for laparotomy, thinking of perforated appendix. And we were shocked by the operative findings. I'm not sure if it's clear. So when we opened up the abdomen, it was a cocoon abdomen. So cocoon abdomen is a surgical term we use for a finding where there is omental caking, peritoneal deposits, adherent small bowel and abdominal contents to each other, suggestive of a very severe inflammatory condition or an advanced malignancy. After doing some form of adhesiolysis and dissection, we managed to find that there is a palpable tumor at the sigmoid colon, which is very surprising in this case. So as I mentioned earlier, it was a cocoon abdomen. There was a tumor in the sigmoid colon, peritoneal deposits everywhere. So we did a ileostomy to prevent him from getting intestinal obstruction in the future, closed up the abdomen and came out. We explained to the family members and the patient, did a sigmoidoscopy and confirmed that it was adenocarcinoma of the sigmoid colon, biopsy taken which revealed adenocarcinoma. Now, this is an advanced disease. He received palliative chemotherapy. He could only tolerate about 3 cycles. And then he went downhill and he passed away 6 months after the laparotomy. Okay, the second case is quite classical. The only thing is the age, 37, but he presents with typical symptoms of altered bowel habits, mucoid stools, tenesmus, loss of appetite, and a very strong family history of colorectal malignancy. Examination unremarkable, digital rectal examination, no mass, hemoglobin of 10.6. I would like to highlight that HB of 10.6 is not normal for a 37-year-old fit individual, more so if they are smokers, male patients. So that should strike something very good. The healthcare physician picked it up and straight away referred for colonoscopy. And we found that there were two tumors, one fungating polypoidal growth at the sigmoid colon. Managed to negotiate the scope through. We reached the ascending colon, right side, also a similar polypoidal looking mass. So this is something we call synchronous tumors, where there are two colonic malignancies occurring in the same setting. We biopsied these lesions. HPE revealed high-grade dysplasia. Now, even though HPE is not adenocarcinoma, but when we have a gross finding like that on colonoscopy, we treat it as adenocarcinoma. CEA is 2.2. I'll explain a little bit about what CEA is later, but CEA is a tumor marker, stands for carcinoembryonic antigen. It's just to highlight that not all adenocarcinomas of the colon secrete CEA. As you can see in this case, it is not raised. CT scan shows that thankfully it's not an advanced disease. It is localized to only the colon. So he is for curative intent. We did a total colectomy or pan-colectomy, we call it, with ileorectal anastomosis. This is the specimen. This patient is currently, has already completed his adjuvant chemotherapy and is under our follow-up now for surveillance. How alarming is this situation? Now, I have presented two patients, 13-year-old, 37-year-old. Should we be alarmed? Is this just a one-off case? How bad, how grave is this situation? So let me share with you a little bit on HRPZ data on what we have collected over the past few years. So from January 2019 to December 2021, we collected data. We have 208 colorectal malignancies. 54 of them were less than 50 years old. It is generally internationally accepted that 50 and below is deemed young colorectal cancer. So you can see that almost 1/4 are less than 50 years old. Okay, to make it worse, only 3% had a strong family history. So that's even more worrying. The next worrying fact is it's increasing in trend, 17, 23. And finally, all these patients present in advanced stage. Means these tumors in young patients are aggressive. Stage 3, 55%. Stage 4, 35%. And only 3 patients with stage 2 disease. Rather worrying, I mean, in my opinion. So now that we know patients are at risk of developing colorectal cancers, it's so rampant, we get young patients developing colorectal cancers. So who gets it? What are the risk factors? The sole most important risk factor for developing colorectal cancer, and is the basis of our screening protocol today, is family history of colorectal cancer. Any family members with colorectal cancer should be worried and should be looked out early and scoped as fast as possible. There is a small entity of hereditary colorectal cancer syndromes. I have highlighted 2 there, FAP and HNPCC, which are rare, but we should look out for, especially when we are talking about young colorectal cancers. Other risk factors: smoking, 16% greater risk. Smoking because of the release of free radicals. Some of the smoke enters into the GI tract, irritates the mucosa by the free radicals and develop cancer. Diabetes mellitus, insulin, high level of insulin, mainly type 2 diabetes, high level of circulating insulin, insulin-like growth factor, is a pro-inflammatory hormone and it increases your chance of getting colorectal cancer. Overweight, BMI of more than 25, mainly leptin is responsible. Leptin is a hormone secreted by adipose tissues. And these leptin is also pro-inflammatory and it leads to development of malignancy. Alcohol consumption, more than 30 grams per day. To give you an idea how much is 30 grams per day, 10 grams is 1 unit. A pint of beer is 1 unit. So if you have 3 beers per day, you're at risk of developing colorectal cancer. So a pint of beer is a glass of beer. Okay, now we have gone through these young patients. We have gone through our HRPZ data. Now it's the most important part of my presentation, which I'd like to highlight to everybody here in the audience. When do we start screening? So we have drafted a colorectal carcinoma guideline, CPG, a clinical practice guideline, in 2017 by a board of colorectal surgeons plus gastroenterologists. And so far, this is what we use to screen patients. So, first things first, assess the patient symptoms for colorectal cancer. Symptomatic or not symptomatic? So symptomatic is this flow and non-symptomatic display. Okay, now I'm sure you're wondering, if somebody has a symptom, why is it still called screening? So why is it put like this in our guideline is that because these patients don't volunteer the symptoms to you. When they come to the clinic, they have eye pain, gout, knee pain, oral problems. They never tell you that they have colorectal cancer symptoms unless you ask. So that's why during the screening process, you have to ask. And that's when we consider it symptomatic. So we'll go to the right limb first, the symptoms one first, and then I'll talk to you about those that are completely asymptomatic and just screening because we want to screen. A bit busy, I'll show you the next one. So these are the symptoms everybody should know of, any healthcare professional should know and should alarm you for a consult or a referral. Rectal bleeding, mucoid stools, loss of weight, loss of appetite, abdominal discomfort, altered bowel habits, perineal symptoms like itchiness, perineal discharge, perineal pain, tenesmus. Tenesmus means sensation of incomplete voiding. After passing motion, you still feel like there's something there. Constipation, anemia, and of course, a palpable mass. Further history, patients may not tell you this, you have to ask. So I like to highlight something called altered bowel habits here. So this is something, if we can pick up early, is very important. So there are two things here, alternating bowel habits and altered bowel habits. Altered bowel habits means alteration in your bowel habits. Before this, I passed motion once a day. Now I'm passing 4 times a day. Something's not right. Alternating bowel habits is constipation for 4 or 5 days, suddenly having diarrhea another 1 or 2 days. So basically, people use it interchangeably, but it's a different thing, but it means the same thing in the end of the day. These patients are at high risk of developing colorectal malignancy, and this is one of the symptoms. Perineal symptoms I mentioned earlier, and abdominal examination. I'd like to highlight full blood count again there because many of times that is the first sign, especially for right-sided chronic malignancies. This slide is to show how fast you need to refer somebody for colonoscopy. So the earlier 2 slides have already shown when do you refer, and this slide is how fast you need to refer. So basically, alarming symptoms or no alarming symptoms. Alarming symptoms, fresh blood, blood mixed with stools, altered bowel habits, significant weight loss, unexplained anemia or mass, straight away call us up. Now we have even opened up colonoscopy to be given appointments via Klinik Kesehatan. You can call directly and get a colonoscopy without a problem. Now, if they don't have these symptoms, okay, the limb on the right limb, the right side, is to show that if you ever have a hunch, if you're not sure, could this be colorectal cancer, could this not be colorectal cancer, it's up to the primary physician. You want to treat the symptoms first and have a look again, it's up to you. If you feel that you're worried, no harm, just give us a call. We will schedule patient for elective colonoscopy. Doesn't matter, within 6 weeks, 4 weeks, no problem. This is the part where they got no symptoms. This is when we are talking about real screening. Somebody has got no symptoms, never presents with any history of abdominal pain, nothing. When do we screen? So it's clearly written in our CPG that for somebody with no symptoms, no family history, all the focus history is negative, you can offer a simple immunochemical fecal occult blood test when they are 50 and above. Cutoff is 50. 50 years old, any Klinik Kesehatan has this kit. It's a simple, non-invasive, easily available, cheap, and ethically acceptable test to be performed, and it is of utmost importance. Let's say patient has got positive, you just scope the patient. Sometimes there can be false positive, but at least we have screened the patients. There are reasons for false positive as well. If negative, then you repeat the following year. So this is what I mentioned again. Anybody with family history, they immediately become moderate and high risk. As you can see clearly documented in our CPG here, anybody with any family history of colorectal cancer, be it first degree relative, second degree relative, mainly first and second degree relative, they're already into the classification of moderate risk. So when do you scope them? At 50 years old, no need to do IFOBT, just refer for colonoscopy. If the colorectal cancer in the family happens at 50 years old, then you should scope them at 40 years old, 10 years before. Why? An adenoma carcinoma sequence takes 10 years to develop. That's the whole basis of it. And that's the commonest pathway to develop colorectal malignancy. Okay, the category 3 high risk, you can see the first point there, colorectal cancer at 50 age and below. Straight away, you are high risk. Immediately at 50 or even before 50 years old, if somebody in the family has got 50 years old cancer, at 40 years old, you should scope. So IFOBT, I repeat, IFOBT is only for no family history. The moment you have a family history, especially first degree or second degree relative, straight away colonoscopy at 50 years old. This is a slide on what we hope to find during a colonoscopy. Now, that polyp on the right and on the left that you have seen are benign polyps, and these are adenomas. And if we do a simple polypectomy for them during the first colonoscopy, we prevent these polyps from becoming a cancer 8 years down the line. 8 years, 10 years down. So this is what we hope to find, and this is what we want to find during colonoscopy, especially for screening. So the recommendation tree there is more for surgeons. How often do we need to repeat and surveillance the scope, repeat the scope after a polypectomy? So we divide polyps to high risk and low risk. High risk we scope straight away. We scope in 3 years. Low risk is 10 years. Rather busy slide, I know, but this is just something I have to mention when it comes to young colorectal cancers, that there are something called hereditary colorectal cancer syndromes, where there is a defect in a tumor suppressor gene, or there's presence of an oncogene, which leads them to develop colorectal cancer at a very, very young age. So familial adenosis polyposis is one of the diseases where we scope them, and even at 10 years old, we start screening, especially if there's a first degree relative diagnosed to be having FAP. Lynch and HNPCC, a bit about 20 years old, we start. Peutz-Jeghers syndrome, 8 years old. Juvenile polyposis, 15 years old. And MYTH-associated FAP, also at a younger age. So this is for the general public. Anybody that you suspect having a hereditary colorectal cancer syndrome, like I mentioned earlier, that means anybody in the family who has been diagnosed of having FAP, Lynch syndrome, you can straight away refer to a colorectal center where there's a colorectal surgeon, because this patient needs to be managed by subspecialty level care. This slide is to explain about CT, MRI, and CEA in the role of screening. CT scan, MRI, no role in screening. It is for diagnosis and staging. For colon cancer, CT scan stages and helps to diagnose. For rectal cancers, you can use an MRI for the D and N acute staging. CEA is something I have to emphasize here. CEA is not a screening tool. CEA is used to monitor progress, monitor recurrence, and monitor response to treatment. So CEA is not something to diagnose. I know out there many GPs are just ordering CEA and referring for high CEA. CEA is not very sensitive for colorectal cancer. It can be raised in many other conditions: medullary thyroid CEA, GI malignancies, pancreatic CEA. CEA can be raised as well. So use it correctly. Okay, this slide, I want to show just one part actually. If you can see here, the second line showing the 5-year survival, the third line. Stage 1, stage 2, stage 3, stage 4. The 5-year survival of stage 3 colorectal cancer is up to 60%. This is very high. So what I'm trying to emphasize here is when we pick colorectal cancers up early, the outcome is really, really good. This is not comparable to other cancers, pancreatic cancers, hepatobiliary cancers. If you get diagnosed, prognosis is grave. Whereas for colorectal cancers, up to stage 3, you can see 5-year survival is 70 to 60%, which is very high. The chemotherapy regime for colorectal cancer, 5-fluorouracil base, is very effective and outcomes have been really good. So if we pick up early, treat early, patients get to live an extra 5 to 10 years, and it's very, very important. A little bit on treatment. This is just what we do, probably more relevant for the surgeons or the surgical trainees. For colonic malignancies in general, we operate first, followed by adjuvant chemotherapy, and then we surveillance. And then for stage 4 is just palliation and operative only if there are symptoms. Rectal is different a bit. Whenever we find a rectal malignancy of T2, N1 and above, we usually give radiation first. Shrink the tumor because it is associated with less risk of local recurrence, maybe sphincter preserving as well, and then only we operate. And then adjuvant chemotherapy thereafter. So this is more on what we do once we diagnose patients. So this is my last slide. Thank you very much for your attention. And I'm more than happy to welcome any questions, and I will try my best to clarify as much as I can. Thank you very much. So currently the evidence base, according to our CPG, there's a few evidence that was quoted. The clearest and the most significant one is the family history. Lifestyle modification, diabetes, obesity, smoking, and there is another controversial part about red meat diet, but that is not proven as well because there is contradictory data. There are 2 studies showing data. So processed meat and red meat diet of more than 100 grams per day. There is one study, but it is still controversial. So if you, that's a slightly higher risk at developing. Has got the most. Oh, I didn't do that data on which state has got more. Different places.
I have stopped taking goreng pisang. Depan mata saya, dia tak mahu minyak. Ini adalah yang one classification kita. Satu lagi cari only water. So yang ini air itu, itu ice cream. Ini kalau ini orang sudah ambil sampel minyak sebab pasti itu minyak juga. Bukan satu tempat, tapi kalau yang itulah ada sekali satu lagi yang kita kita tahu ada study yang
the only thing for colorectal cancer is that controversial statement of processed meat and red meat. There are also 2 studies. One like steak, 100 grams per day. 100 grams is as big as our daily. Not every day.
Whether meat that we fry or or we have this is like we study so that high risk of
not significant.
But usually processed meat. There's a lot of processed meat in our when buy burgers, whatever, when those meat, what the meat, it's been processed. Those are the meat that are really alarming, not the red meat, the fresh meat that we regularly taking locally. So and it's really sad because our patient normally the moment they get cancer, they stop eating meat at all, and they start having nutrition problems. The recovery is going to be very bad. They just rely on this sometimes. After being diagnosed, this will happen. So, jadi kamar expose because the overcooked food, so it's not good as well. Because then we get bring it from so you know that people addiction very difficult. If we back to the first question by about whether in Malaysia there is in terms of the proportion based on state we have a very small population. I have a study on diet modification of it. It will transport very big. If you study itu tak boleh nak point tu because kita tak boleh ada subject our sample jadi makan benda tu kan. as we're having it's not easy, and the way we are reporting also still not up to the standard. But what is more important when we are presenting this young advocacy or early onset advocacy is that because kita nak everyone cautious lah. Whatever level you are, meaning kalau you are doctors, meaning if you see patient, you don't indicate, oh, this is less than 50, this is not cancer. You know, you still have to be very cautious kalau you are doctor. Kalau you are not doctor, you have your family and all that. Kalau ada symptom, please see the right doctor. The work is to see the right doctor. There are many cases being seen by doctors, by ignorance and all that. The family datang lambat juga, even to our center, into our visual time and all that. So this is something that kita nak bagi bulan question. And the problem, our screening is still fixed to 50, walaupun kita still 50 pun catch up dia tak sebagus mana. Kalau kita reduce to 45, then akan incur cost. So bila kita tengok cost, kalau kita screen on 45 years old, dengan pick up rate dia tu very low lah. So kita dah sure. But I always stress that kalau you are the patient yang less than 50 ada simptom, ramai yang tak faham. Screening ni kita screen those yang tak ada simptom, perfectly normal healthy population. Yang tu kita screen. Ada yang risk dia mesti tahu. Tapi kalau dah ada risk, kurus, buat besar pun tak faham, you know that. And before that, then we straight away we don't do screening anymore. We go to colonoscopy. That's it. Because right now, every patient is reduced even. They find inside the 50 reduced 48 or 45. Kita tak boleh nak buat scope. Patient pun two samples pun. Tapi scope pun problem. Kita pun banyak replacement. So back to results saya nak stress lah. Kalau ramai yang reach 50, please lah go for eye quality. Because please go for eye quality at least once. For those yang ada symptom, cari the right doctor. That's more important. And macam Rokmara said, we have to look after our health, our food qualification, our diet, our lifestyle. Ini banyak benda yang environmental factor. Kita yang kita makan. Because the pregnancy, more than 50, incidence of cancer ini dia reducing. This is cover the world. The one in 9, less than 50. So benda ni, it's not our job lah untuk find out apa cause it, because even the world tak tahu.
Ya tu.
Boleh tak?
The speakers on.
Soalan?
Soalan ditanya dalam Okay, so if there are no further questions, then thank you very much, Datuk Ahmad, Pengarah, and Iman Pengarah. So I'll pass it back to the MC.
Thank you so much to Mr. Pranjit Singh for the very fruitful input for the SME today. If no further question, I would like to invite Datuk Pengarah, Dr. Haris bin Muhammad, to give a certificate to Mr. Pranjit Singh as a token of appreciation.
Gambar ya.
Okay.
So before we close our SME for this week, I would like to announce for the next week topic will be ovarian cancer, presented by Dr. Vaini from the ONG department. Thank you very much for your attention.